epidural needle. This is called a TUI needle. We place the epidural with. Someone asked, how do you know when you're in the epidural space? Skill, my friends, skill. Also, we're looking for something called loss of resistance. Resistance. You don't have to be as fancy as I am. We're in your back. We're going through several layers. Skin, muscle, fat, some ligaments. Getting a good little ligament section here. And then we're in what we call the ligamentum of flive. Not the real word, but it's what I call it in my head. It's a stiffer ligament, thicker and more dense. And we feel this against our syringe on the back of our TUI needle at this time. Usually we fill it with fluid, although you can do air, although best practice nowadays shows fluid is best. And what we find when we are in that ligament is that this is how it feels when we push on the back plunger of the syringe. A little bouncy bounce. See how it bounces? Millimeter by millimeter, start advancing and checking that we still have this resistance. We're advancing, still resistance, advancing, still resistance, advancing, still resistance. And then, suddenly, in one of our small, minute advances, we have loss of resistance. So as soon as we get that loss of resistance, we remove the syringe, and you're staying nice and still. And that's usually when we say, we found the right spot, stay nice and still for me, you're doing great. Even though we know you're hurting like hell. And then we take the epidural catheter and we thread it through this needle. It goes through the needle, and then we remove the needle. And what's left in your back is this little tiny catheter. Based on how deep the TUI needle was in your back, off these little tick marks. Those are measurements. And there's measurements on our epidural. All these little notches mean something. Based on how deep this needle was, will tell us how deep we need to go with the catheter to make sure that our catheter is in the actual epidural space when we remove the needle. Behind is this little catheter in your back, and sometimes if the catheter is a little bit tilted to one side more than the other, coincidentally, just by placement, can cause more medication to be dispersed on one side more than the other instead of a nice little equal waterfall. If that's the case, you might feel that one leg is more numb than the other, and you call your L&D nurse and you're like, yo, girl, my left leg is so numb and my right leg is not. You need to be lying on the side that is not numb, okay? Your L&D nurse is going to be flipping you side to side. Your epidural is not only dependent on which way this catheter is pointing, which most of the time it is up and down. Sometimes it can just have a slight little tilt. So heavily gravity-based by volume of medication that we are giving. So again, position matters, and that's why you need to be turning side to side, not picking one side. Can't fix it by just positioning. You need to call your anesthesia provider into your room, and what they can do is try to pull back the catheter, and sometimes it straightens it back out. Or they just need to remove the whole thing and redo it and hope that it places better the next time, because sometimes it's just straight up coincidental of just how the catheter tip is lying. Okay, thanks.